Rajesh, who is our president of Vision 2020. So first of all, I would like to Dr. Rajesh Saini to give introduction to the session.
Good evening to all of you. Respected Dr. G.N. Rao sir, chair for this session. Dr. Praveen Vashisht, moderating this session. And all the eminent guests who are attending this important session on refractive errors. We all have to agree that over the years, the need for eye care, eye health has grown to that level. Today, year 2024, is actually the 20th year of Vision 2020, the Right to Sight India. And when we see this consortium of Vision 2020, how it grown from 9-member organization to 175 organization and a network of around 400 eye hospitals. This network of NGO eye hospital working in alignment with the National Program for Control of Blindness, and now after change of the blindness definition, visual impairment. Today's session will highlight the need of refractive error correction, the need of effective refractive error coverage. And when we talk about how to do it, how to maybe achieve it, we need to align with the global strategy of 2030. We talk about 2030 insight now. And I think in our country, we need to think beyond this. We need to think about 2050 goal now, considering the myopia, how it is progressing. And all this, we have shown to the world, can be achieved with collaborations and partnerships. SDG 17 talks about collaborations and partnerships. Government of India really looking forward to strengthen and address refractive error. Recently, we had a workshop at RP Center AIMS where the need for effective refractive error coverage identified, and one means every third person needs this pair of glasses, which is a simple solution. We need to see that how government can create policies for effective coverage, how government can ensure this simple pair of glasses for each individual who needs it effectively. At the same time, the service providers, when I say service providers, the manufacturers of the glasses, how they can bring down the cost of these glasses so that every individual can afford these glasses, and government participation will also ensure it. We have eminent speakers with us. A very good panel discussion is awaiting for all of us. Without wasting time, I would like to invite our chair, Dr. G.N. Rao sir, to address this topic so that every one of us is enlightened. Thank you. Thank you very much.
Thank you so much. What I'd like to do is to split my talk. I have already sought the permission of the Dr. Harpreet Kaur to do that, because myopia is the most critical component of refractive errors. And my colleague from LV Prasad, Pawan Verkicharla, is perhaps one of the most knowledgeable people in this field in the world. Research, clinical care. He happens to be the head of our myopia program at the Institute. So I'm splitting my time with him. What I'll do is a 7-minute broad overview about the uncorrected refractive error, and Pawan will talk for the next 8 minutes out of my 15 minutes allocated to me. So uncorrected refractive error by definition is a presenting visual acuity of less than 612 in the better eye. And all these different components, myopia, hyperopia, astigmatism, and presbyopia. And almost all of them can be addressed very easily with a pair of glasses. According to the World Report on Vision published by the World Health Organization about 2-3 years ago, nearly 2.2 billion people in the world has vision impairment. Out of these, at least half of them could have been prevented or corrected, and 150 plus million are due to uncorrected refractive error. And in India, nearly 10% of all adults above age 30 have uncorrected refractive error. An estimate is uncorrected refractive error magnitude is 85 million in our country. And to that, if we add another 130 to 160 presbyopes, we can imagine the magnitude of the problem that we have in our country. So uncorrected refractive errors has different facets of social impact. Social isolation, impact on education, employment, productivity, quality of life, and also the danger of increased morbidity and resultant economic distress for the people affected and their families. So the impact of uncorrected refractive errors cannot be ignored. And the more recent World Health Assembly and other resolutions are aspiring to achieve a 40% reduction in uncorrected refractive error in the near future. How do we do that? It requires several major areas to be covered. First of all, through eye health promotion and raising the awareness of the problem of uncorrected refractive error, and that indeed it can be corrected, that has to be brought to the attention of the people, public. Second is the recognition of the problem. Third is the correction of the problem through refraction and dispensing. And in addition, in some complex cases of refractive errors, we may have to adopt the techniques of contact lens fitting and refractive surgery. So what is the immediate solution that with what we already have? That is the screening in communities and schools on large scale. And using all the available systems, it is possible that we can begin to blunt this problem of uncorrected refractive error. With focused programs, we can enhance the quantity of people that are addressed. At the same time, we can try and improve the quality of correction of refractive errors. And a very important component of this entire challenge is to supply affordable spectacles for everybody that requires them. And how do we do that? As has already been pointed out by Rajesh, advocacy. Advocacy with all the policymakers. Sometimes it works. If you look at the cataract success story in our country, it happened because of the active involvement of all the three components, the three Ps. Professionals, because they were very interested in doing cataract surgery, excited, because it gives immediate results. And also there is an economic incentive for the professionals in cataract surgery. Second was the policymakers in Indian government for the past 50 plus years has been actively supporting prevention of blindness programs. In fact, India was the first one to have a national program for prevention of blindness, control of blindness anywhere in the world, even before there was a cell on blindness in the World Health Organization. Following the World Bank grant in the early 90s, we went ahead, convinced the government, and the government has actually increased the funding for prevention of blindness program. So with policymakers, cataract had a success. And public is very aware of the problem of cataract, and they also know that cataract surgery is quite successful. Two examples of massive screening programs in the recent past were the ones that attracted the attention of the politicians in the states of Telangana and Andhra Pradesh. In fact, they have become an election manifesto. That's a success of advocacy. If we can really get on to the election manifesto of something anywhere in the world, that's a symbol of success with our advocacy efforts. Can we replicate this? Large-scale campaigns which are done on a mission mode. But the mission mode can last only so long. What we have to do is from mission mode, how do we migrate to a sustainability mode? That is something that we have to think of. That means creating the right kind of infrastructure, human resources, and supply of spectacles. We have to build the capacity for optical correction, contact lenses, and refractive surgery. Vision centers have become very popular, and more organizations are developing these centers of primary eye care. And in our country, we require nearly 30,000 of these if we were to really make a huge impact in the long run. And as far as supply chain is concerned about glasses, we have to learn from other businesses. Dr. Alan Foster used to have a slide with an African girl having Coke bottle tops as her earrings. He used to say Coca-Cola could reach her, but we could not reach her. So there are lessons from all these businesses. How do we reach everybody? Even now when we go into the villages in India, anywhere, you see advertisements of all kinds, but there is no advertisement about our healthcare. So how do we learn from all those experiences of the corporate sector? That's very important. Of course, the impending pandemic is myopia. Almost half the world is supposed to become myopic by the year 2050. Can we really wait and let it happen? No. I think we have to make every effort to control it. Atul Gawande in his book Better said, for success in medicine, there are three core requirements: diligence, to do right, and ingenuity. So, in dealing with the problem of uncorrected refractive error, we require all these three elements together to be a successful program. So now I would like Pawan to come and make his presentation related to myopia.
Thank you, Dr. Rao and Vision 2020 for inviting me to share the stage with great leaders in the ophthalmology. It's an honor for me. And I will quickly take you through an overview of what's happening in myopia. Instead of giving you the solutions, I will be throwing out the challenges that we are facing in the field of myopia. To highlight a quick overview, we're looking at 5 billion to have myopia by the year 2050. That's a big number clearly. And Dr. Rao already indicated about the impact the refractive error is going to play on our children. A lot of times we talk about the direct cost, ignoring the indirect cost. I think they're going to play a big role in child's upliftment in general. Clearly, it is multifactorial. A lot is not known in the field of myopia. We have something, but I think we're still scratching the surface. A lot needs to be done. Thankfully, myopia can be prevented with the evidence that we have. There are options that are available, and myopia can be controlled. And we're looking at every diopter matters. We don't have to wait for somebody to become -10, -9, etc. Even if somebody is at -1, I think we should be really with guns up. And obviously, it is beyond providing a mere single vision correction, and things are escalating or changing much more rapidly, much like the COVID scenario. And unless we are up to date, I think we will be outdated. If you ask me what's happening in the Indian context, this is the model that was developed at L.V. Prasada Institute. We looked at the data that's already published until 2020, and seems like by 2050, we're looking at 48% of children living in urban cities going to have such a problem. And this is not accounting for the COVID. So keep in mind, COVID led to more indoor-centric lifestyle, more myopia. I think these numbers are only underestimate. On the right side bottom, you're seeing a publication by Dr. Rohit Saxena et al., and clearly indicating a shift in the prevalence of myopia in the last decade versus now. We have multiple solutions. People ask, do we have evidence? Yes, we do have evidence. A lot of systematic reviews been published. Clearly, even optical, pharmacological, lifetime outdoors is known to be in favor of myopia control. I think in the past, we are looking at only correction for myopia, single vision correction deal done. Currently, I think we're looking at controlling the progression of myopia, but the future seems like we're looking at reversal of myopia as well, and then prevention clearly. Somebody is -3, we're also talking about, can we reduce it a bit more? There is some evidence coming out indicating that, yes, it's stable, at times it also goes back. So we are on that mode. Coming out to challenges, I will quickly highlight some of the challenges. While we say a lot of treatment strategies available, the clinical trials are conducted in children aged 5 to 15 years of age, on refractive error until -5, -6. Does these correction options that we have, even the pharmacological options that we have, atropine, does this work in cases of high myopia? Young adults do also progress. It's not necessarily that somebody 16 years of age, myopia is in control. Somebody has pathologic myopia, does this actually work? I think there are few unknown answers in that zone. Challenge number 2, the end goal of myopia control, I think, is to ensure there are no pathologic myopia lesions, or to ensure the person does not go visually impaired, or the person does not go blind because of retinal detachment. At this point of time, unfortunately, we do not know whatever treatment we prescribe, is it going to stop that problem? I think the answer is no, but maybe we should wait and watch to ensure we have some good answers. We talk about universal coverage. For myopia, at times the optical strategies are expensive in nature, unfortunately, which means we are catering our services only to a limited population. So maybe there is a need for insurance to come into the picture, much like refractive surgery. Above -6, I think refractive surgeries get that insurance level. Maybe something for myopia needs to be looked at so that the availability is clear to everybody. The million-dollar question is, which myopia control strategy is best? I think it's difficult to pinpoint and say, this is the strategy that is fantastic. We have to look at long-term complications. We have to look at, if a child is wearing some defocus lenses, can he drive? What's happening to the peripheral vision? Somebody using atropine, what are the long-term complications? In clinical settings versus the randomized clinical trial, seems to be there are some discrepancies. I think we need to map that up. Challenge number 5, the awareness. We need to look at bottom of model is what my thought process is. When you say that the myopia control strategies are available, the eye care practitioners are aware of this, I think clearly not everybody is practicing myopia, but whoever, the end customer or the patient somewhere in a rural setting or even in an urban setting is not aware of existence of these myopia control options. I think somebody is wearing Coca-Cola coins. I do not know, maybe we should do something so that everybody can talk about refractive correction options so that the myopia can be controlled. Again, another million-dollar question is, when do I start myopia control treatment as a practitioner? When do I stop? When do I trigger for myopia control? Again, we developed some consensus criteria. We called it IMPACT, published in IJO last year. Multiple entities to look at. To start with, I want to highlight that just because somebody is myope doesn't mean we need to start looking at control. Is it really axial myope? -6 can be a keratoconich eye. -6 can be a pseudo myopia as well. Just because somebody has -9 does not mean it's progressing. It could be -9 for 5 years. Why are we talking about myopia control strategies? I think there is need for more awareness among the eye care practitioners, among the general public as well. I think it's time to act now. With this, I thank you for attention.
And effective refractive error coverage, more than alphabets that meet the eyes. Dr. Padma.
Good evening. Thank you for this opportunity. It's very humbling to share this space with legends like Dr. Rao, who's actually been partly someone who inspired me to do community ophthalmology. I hope that in the next few minutes, I can walk you through the concepts of effective refractive error coverage and WHO's SPECS 2030 initiative. At the outset, I want to acknowledge Dr. Stuart Keel, who has kindly permitted me to use some of the WHO graphics to explain this to you. Universal health coverage has been identified as a sustainable development goal. And for any service coverage to be effective, quality is paramount. The burden has been spoken about at length by the past speakers, but suffice it to remember that 1 in 10 have uncorrected refractive errors for distance, and 1 in 3 have near vision impairment. So, how do we define unmet need? Somebody with binocular visual acuity of less than 6/12, who has no available correction, but improves to 6/12 or better with pinhole or best correction, represents the unmet need. Somebody who is less than 6/12 binocularly uncorrected has a pair of glasses, but does not correct with that to 6/12 or better, represents the undermet need. Met need, of course, is someone who walks in with a correction and has good visual acuity. This would be our dream figure for the future. So till now, we used to talk about refractive error coverage, which just talked about the proportion who received services. We now have to take it further to include good outcome. And so that would be the definition of effective refractive error coverage. In this schematic, somebody who can see does not have a need. Somebody who can see with the glasses they have has a met need. Similarly, somebody who could not see with the glasses, as I just said, was under met need, and somebody who does not have glasses has the unmet need. And so the formula includes that EREC is met need by met need plus undermet need plus unmet need into 100. Globally, EREC, as reported in 2019, is about 43% for distance vision and about 20.5% for near vision. The good news is it has improved by 19% since 2000. What this also means is that the undermet need represents the quality gap and the unmet need, the coverage gap. Refractive error coverage may look as big as 44, but effective refractive error coverage is still only 36%. EREC for near vision is being looked at more closely now, and if a person is less than N6 uncorrected, has a pair of glasses which do not improve to N6 or better, that is again undermet need, does not have available correction, has unmet need, and somebody who can read with his glasses is again met need. The situation analysis, I have just taken one recent study to demonstrate this. EREC for distance is about 37.4, and that for near, about 31.8%. WHO has set a target for us that by 2030, we should have a 40% increase in effective refractive error coverage. This should include both near and distance vision, and so forth. The implication for India would be that we should move from 30% to about 70% in less than 6 years. So how does the WHO propose to do this? It has launched the SPECS 2030 initiative, which rests on 5 pillars, which are spelled by the acronym SPECS: improving access to services, building capacity of personnel, improving population education, reducing the cost, and strengthening the surveillance. The vision is, of course, that everyone who needs a correction will have one easily. In addition, it has also laid out desired outcomes at the country level. This looks like a busy slide, but we'll go through that very quickly. So for the services segment, we need to focus on policies, adopt quality standards, integrate procurement and inventory, and integrate with the primary health centers. I'm pretty sure Dr. Praveen will tell us more about that. Remember that the quality of the spectacles also have to be kept in mind, and there are prescribed indicators for this. Personnel has always been a challenge, but we hope to increase the workforce, train them, and foster innovation for screening. To me, it seems like Dr. Rao had also alluded that awareness and demand generation would be the key challenge. We need to implement campaigns, include eye health in other health programs, implement policies, and increase the demand for spectacles. For children, we will need to adopt as many models as are currently available in the country because no one size fits all. We will need to sensitively engage with the cultural perspectives to meet this demand. For adults, it has also been shown that the most near vision impairment happens in the working age group, so perhaps it may be worth considering interventions for demand generation at the workplace. Barriers to refractive error coverage, affordability is the main one, and a lack of felt need for presbyopia. This led us to do a study in Velo where we looked at presbyopia, and about 50% prevalence. And for their usual activities, it was seen that most of them who said they had a lack of felt need had a visual acuity of N12 or better. This may mean that demand generation be done with evidence, and maybe N12 can be the new cutoff if that is what it takes. As far as cost is concerned, insurance, trade barriers, and sustainable mechanisms need to be looked into, and effective ways have to be looked at to cut costs where ready-made specs can do it at 1/4 the cost. If there is no surveillance, there is no program. So we need to integrate this with the hospital information systems, periodically report EREC, and implement quality assurance programs. The WHO intends to do this by the private sector dialogues, the SPECS network, and the SPECS normative network to unify stakeholders, make evidence-based advocacy activities, and strengthen discussion. What can we do? We who are here in this hall today, we all need to advocate for the need to strengthen the services using tools that the WHO can provide. And I'm pretty sure each of us can adopt one area, whether it's a school or a locality, whatever it takes. Organizations and private sector representatives have been invited to take part in this. Lastly, I have just one word of caution. As of today, presbyopia brings every adult to an eye care provider in their lifetime. Current strategy for screening for preventable blindness like glaucoma rests on opportunistic screening. While focusing on EREC, we should not compromise on comprehensive eye examination. Thank you so much for your hearing.
It was a fantastic talk, and we come to learn about SPECS. That's something new process which has been adopted by WHO recently. Now I would like to request Dr. Harpreet Kaur Kapoor to talk about specifically about vision screening program for school-going children.
Very good afternoon to all, and as Padma said, it is indeed an honor and privilege to share the space with legends like you, sir. And of course, we do have the 6-minute challenge also, and I'll try to pass the test in time. So, yeah, wish me luck. So as we all know, vision impairment in children can have long-lasting consequences, and good visual acuity is not only important for effective learning, but also has an impact on behavioral development in children. Poor vision can lead to negative influence on academic achievement, quality of life, and even potentially the future economic status of a child. So, of course, the unmet need we are all familiar with, and some of the factors contributing to the refractive errors not being addressed, even though the solution is simple, is lack of awareness at the community level. Children wouldn't even know that they have a visual problem. And then, of course, limited availability of refractive services, affordability, cultural stigma, and at the level of policymakers, it is generally, the sad state is that eye health might not be a priority for policy makers, and then, of course, the lack of evidence there. School, of course, being the first formal space for learning, and so it gives us an opportunity to catch them young. So we have the opportunity to detect various refractive errors, diagnose amblyopia, and timely intervene to address lazy eye, as we all call it. And then, of course, to close the loop, it's important that we do provide the spectacles also, and school-based examination or vision screening programs does raise awareness as well. And other eye conditions also get diagnosed at an early stage and treated timely. Conventionally, school screening programs were carried out, or are carried out rather, by eye health teams who go ahead, do the screening, prescribe glasses. But some of the issues in such a program is that the screening might not be efficient, very efficient per se, and cost effectiveness is another issue there. And then ensuring that the child wears spectacles. So compliance is a major issue, and then sustainability, of course. Teachers training program now over the past 2 to 3 decades has been recognized as one of the cost-effective and efficient model for doing school screening programs, and where all of us know practical training is given in vision screening, and of course the children who are diagnosed to have vision less than 6/9 get examined by the eye health teams, and glasses are prescribed, dispensed. And of course, in this case, the compliance improves because of the adherence and sustainability from the sustainability point of view too. Peak, yeah, we have been looking for innovative solutions. So Peak School Eye Health System also has been used by several organizations across the globe. It is quite prevalent in, highly, I would say used, or in Africa especially, several regions in Africa and Pakistan as well. In fact, in Pakistan now the government has kind of adopted the PEAK programs, and it might be supporting in the next 2 years. It will become a government integrated program there. So, yeah, so PEAK technology does kind of give us, it helps in, I would say, improving the uptake of services, and it gives us an opportunity to monitor the programs very closely so as to close the loop. And of course, cost effectiveness is questionable there. I would just like to touch upon the School Eye Health Rapid Assessment Tool, which is being developed by PEAK, the PEAK group. So we know that there is lack of evidence for prevalence of refractive errors in children. RUB and several population-based surveys are available for adults, but yes, for children, there's not enough evidence. So This tool which is being developed will be of value in kind of informing the various stakeholders in planning, implementing, and monitoring of SEH programs. First module, which is the assessing the magnitude and nature of local needs, has been piloted in one of the CBM supported programs in Pakistan just last November, that was. Okay, just to wrap up some of the best practices in school screening, so we know teachers training has been proven to be an efficient and way of conducting the school screening program and helps in sustainability. Just to go into a bit of detail there, dive deeper into the program. So it's important that we kind of, see that quality training is provided to the teachers, which reduces the number of referrals and the cost of the program as well. Train 2 teachers from each school, use single letter E or one row of optotypes. And of course, we need to kind of also consider whether we still stick to the 6/9 cutoff or maybe 6/12. Dr. Rohit, Dr. Praveena here, they had a publication regarding the favoring the 6/12 cutoff point, which proved to be more cost effective. And then, of course, going on to some of the other best practices, I think it's important that vision screening becomes mandatory. We need to advocate for that. It should be mandatory at admission and included as part of the annual academic calendar. And of course, then it's important that we don't just give spectacles free of cost we all do realize that it shouldn't be just given away to everybody, but yes, to children with belonging to low socioeconomic strata, and will be helpful if frames are selected by kids themselves. It helps in, adherence. And then, needless to say, evidence-based planning is a must. And I think as we look forward to kind of addressing this burden of blindness, global burden of blindness rather, so it is important that we, move towards integrating vision screening programs and comprehensive school health programs. And of course, last but not the least, programs should be inclusive. Yes, from CBM standpoint, definitely that is the most important point there. And thank you for your patience.
Thank you very much, Dr. Harpreet. Just to adding the learnings, what we are having in our school screening programs, obviously doing with CBM and Orbis and Mission for Vision. I think selection of spectacles and choosing the spectacles by children is one of the methodology which is helping children to wear spectacles. And another thing is, obviously, when we give one pair of spectacles, the compliance after 3 months, 6 months, and a year is equally important that whether the child is wearing spectacles or not. So again, the learnings are continued and we all will address these challenges in near future. Thank you very much. So now I will request Dr. Praveen Vashisht to highlight the government initiatives and strategies for achieving effective refractive error coverage. Dr. Praveen.
Thank you, sir. In fact, I've been asked to talk about effective refractive coverage. In fact, how government can achieve this coverage. Dr. Padma has just mentioned, given the definition of effective refractive coverage. In fact, the issue is that at this stage, we are not aware what is the effective refractive error coverage in our country. This is a bigger challenge. As sir has just mentioned, that myopia is an emerging epidemic, and probably all of us are aware that we are leading towards in 2050 that 50% of the population may be myopic, 50% of Indian population. And beside this presbyopia, we know nearly 60 to 70% of people above 40 years of age, they are already having presbyopia. In fact, Dr. Rohit is there. We have done this meta-analysis. As per this meta-analysis, before COVID, we were finding that the prevalence of myopia, refractive among children, is nearly 8%. And not only in urban population, it is also increasing in rural populations. That's something very worrying, that in India, the burden of myopia is increasing. In fact, it is estimated at this stage, this is around 20%, 3 times increase in last 20 years. So the estimate that this will be around 50% by 2050, it seems that it may happen. WHO has taken this initiative that to achieve universal health coverage, we need to increase our effective refractive error coverage. By 2030, it is not 40%, it is 40% point. If we have 30 at this stage, then we have to increase to 70. So it is a number, it is point percent, it is not percentage. By percentage, it may remain around 40%, but it is 40 point percent. That need to understand actually. NPCB, we did this National Blindness and Visual Impairment Survey. We could actually calculate the effective cataract surgical coverage, but we were not able to calculate the effective refractive coverage. After that, we have done few studies, and as per those studies, I can tell you the coverage in our country for effective refractive coverage is around 25 to 30% at this stage. In better performing districts, in Gurgaon, we could get up to 60%. But I believe it is not more than 60% in any of the districts of the country. This is assumption at this stage. We are doing, in fact, we plan to do survey. This is the first initiative which Government of India is now taking. That, in fact, today is a meeting in ministry. We plan to do this effective refractive error coverage survey in country. It is planned that we'll be doing it in 30 districts, and it will be done in two phases. One in 18 plus population, that is for myopia as well as for presbyopia, and other in school going age group to 5 to 18, 5 to 17 age group. So these two survey will be conducted, and our plan is to actually assess the current status, and in future we plan how we achieve the coverage finally by 2030. So this is first strategy which we are going to implement now. And as we know that even refractive error, by working in hospital alone, we cannot achieve. It is like an iceberg phenomena. The people are in community, so we have to reach to community. The first strategy, which Dr. Madam has just given a detail about this thing, that what is school vision screening program. We feel proud that India was among those countries who started this school vision screening program under the national program way back in 1994. And under this, the spectacles are being provided totally free of cost. It's a low-cost screening program, non-invasive technique using 6/9 cutoff, where school teachers are screening it, reliable, rapid, and acceptable program. So all criteria of screening are there. It's a three-pronged program. Stage 1, teachers are being trained, and they do the initial screening using 6/9 cutoff. Then we are referring to ophthalmic technicians, they do the refraction, and finally it is going to opticians, where they provide spectacles, and that too free of cost. This is 6/9 cutoff. The question is whether 6/9 cutoff is right, or we need to change to 6/12. WHO recommends 6/12. We had a detailed discussion. We wanted that we should take 6/12 cutoff. But the Government of India says, if teachers are screening, teachers are non-medical person, then you can use 6/9 cutoff. They let them refer more number of children, and the ophthalmic technician, they can screen using 6/12 cutoff. That was like reason given by Government of India for using 6/9 for school teachers. If an eye care worker is doing, probably it is better to use 6/12 cutoff. Numbers. What is the actual number needed? 8%, 10%, what is the amount? This number is for India. Just see, for a population of 140 crore, nearly 25 crore children need to be screened every year. 25 crore. And we need to provide 2 crore spectacles every year. This is such a huge country. And what we are actually getting is our NPCB target at present. We are happy to say that we have increased to 15 lakh. Before that it was 9 lakhs. From 9 lakh is 60% increase. Now the target is 15 lakh. But 15 lakh is it's around 7.5% of the actual population base need in the country. That we need to understand. So time bata dena, main just jaldi khatam karu. So these are the major issues. Yes, but myopia burden is not actually known. What is actual burden? What the frequency of screening? Once in 4 years we recommend as per a national program. But we know it very well. The burden as well as the incidence and prevalence of myopia is so high that we need to screen children every year in the school, not once in 4 years. Of course, the data is not available. We have a regular reporting in NPCB. It is just number of spectacles given to children. What is the prevalence of myopia? What is the cutoff levels, etc.? No data is available with government. So we need to strengthen program. We know it very well that there is need for technology upgrade. We need smartphone apps so that entire data can be collected at one point, and of course it can be shared, and even a feedback can be given at all level. Annual screening, 6 by 12 cutoff, these are the other strategies which are needing. And of course, people have talked about need for quality spectacles and proper delivery of spectacles. This is a need. The third important strategy which is being recommended is the vision center base. You know, we need 50,000 population, we have one vision center. There is need for at least 20,000 vision center in the country. Probably it is the best strategy. We need to go from school base to vision center base, where ophthalmic technician is available. Parents can go and show children, and screening can be conducted. This is another model, and I have must have shown this presentation so many times. The vision center is the only model by which we can think of achieving universal coverage in the country. Of course, human resource ophthalmic major technicians, it's a major challenge for our country. The various associations says that there are nearly around 70,000 ophthalmic technicians are available in country, but I doubt, as per our data which we collected in HR survey, the number is around 20,000 only. The rest we have to think about how to increase the human resource, infrastructure, manpower. All these are challenges, and we need strategies. Asha worker are one way where we can involve them through health and wellness centers, and they can be involved in initial screening of all the children in entire population for visual impairment. RP center has shown that a medical college, a hospital can achieve. We have even provided more than 600,000 spectacles in last 10 years. So this is an achievement. Probably other hospitals can also do. But probably the best strategy is prevention. Prevention at school level, where we can increase the outdoor activity. We just shown a slide. From 50% we can reduce to 28% if we are using preventive strategy. That means outdoor time is increased in schools, and also if we reduce the near work time for school children. Probably this is one strategy which need to be adopted all over the country. So finally, if you want to select the best strategy, it is the integrated model. All things should be combined together so that we can achieve universal eye health coverage in the country. Thank you very much. Thank you.
Thank you very much, Dr. Praveen. Now I would like to request Dr. Amit Gupta to highlight overview of refractive surgical procedures.
I'm a refractive surgeon, and proudly so. And I work for the government, so there is no financial interest here. And I would like to thank Dr. Harpreet and Vision 2020 for giving me this opportunity to be a part of this very interesting and meaningful session. So if we look at refractive surgery, it's any eye surgery that's used to improve the refractive state of the eye or to decrease the dependence on glasses in patients. Now, if we look at the eye, the cornea and the lens are the two major refractive things in the eye, and that is why the refractive surgery can be either cornea-based or lens-based. We have been through these statistics, and we look at myopia, and it's estimated that by 2050, more than 50% of the population may have some kind of a refractive error. And almost 10% would have a high myopia, which is actually a pathology. It's such a disease for patients to have. Now, what options can we offer for refractive vision correction to the adult population today? And I just couldn't resist putting this slide, that as far back as 1896, man has always wanted to play with refractive errors, try to take them away, and try to improve them. And the history goes back almost 125 years or more. But it was actually in about 1987 that the first PRK was performed, and in 1995 that it received FDA approval. 1999, the LASIK got the FDA approval, and in 2016, the SMILE got the FDA approval. Now, when we talk about lasers, there's a tendency to have what is excimer laser, what is femtosecond laser. So I just put in a couple of slides. Like when we talk about photoablation, what happens is there's a laser mechanism by which the molecular bonds are broken using high energy UV photons. And what happens is that due to that there's a promotion to repulsive states between the molecules of the cornea. There's dissociation, there's an ejection of fragments without causing a necrosis, which goes in the form of a plume, and then therefore it leads to practically the disappearance of tissue and flattening of the cornea. On the other hand, the femtosecond laser works by photo disruption, so there's a little laser spot, and that generates a plasma, and it just expands to form something known as the cavitation bubble, and that is how the bubbles join together to create an interface. And if we have a little overview of what we can do with the eye to get rid of refractive errors, they have been majorly classified into something which causes incision of the cornea, surface ablation, or laser-based or microkeratin-based incisional procedures, or lens-based procedures. So this is the reason why radial keratotomy and astigmatic keratotomy is no longer popular, because it used to cut up the cornea and create so many other problems in patients' lives. If we look at the procedure of the surface ablation, the basic principle is that the surface of the epithelium is removed from the cornea, and then it is followed by excimer laser photoablation, and this causes a change in the corneal shape, and we can get rid of the refractive error. Slides are not moving. Okay. All right. So the in thing right now is what is known as SMILE, which is the small incisional lenticular extraction. So what it entails is just removing a stromal lenticule from the eye, and thereby changing the corneal shape and causing the removal of the refractive error. I'm sorry, I apologize, some of the videos are not working. Yeah, and in case of people with high myopia, which is more than -10, -15, -20 diopters, there is something known as an phakic intraocular lens, which is injected into the eye, and thereby it gives good vision to these patients without actually causing a change in the cornea, which would actually lead to so much induction of higher order aberrations in these patients. Other techniques which are very selectively practiced are putting in some kind of rings, especially for diseases like keratoconus. It can really improve the quality of life in these people. Also other inlays, stromal and other inlays, which are used to correct some of the refractive errors. And with the excimer laser platforms, it is possible for us to actually take care or try to not induce so many higher order aberrations, thereby leading to a much more superior quality of vision. Also something known as topo-guided ablation. These are all platforms which we can use with the excimer lasers. But we should not forget that these refractive surgeries have a lot of complications, and it is only with meticulous protocols coming into force that my personal experience is that the incidence of complications has now gone down, but it does exist, and this is something which has to be communicated to the patient when the patient comes to us wanting refractive surgery. I was trying to find literature which would compare, I'll just wind up in 1 minute, compare different types of the outcomes of different types of refractive surgeries. So I did come up across a network meta-analysis. Now, if the volume of cases is shown by the size of the dots, and unfortunately this is a few years old. I think we can look forward to another such publication coming in. But out of a very complicated kind of analysis, including the surface under the cumulative ranking curve and comparison of predictability and safety of these procedures, this study has concluded that actually, including the contrast sensitivity in this patient, that there is no statistically significant difference in either the visual outcomes or the visual quality amongst all these surgical procedures. They all appear to be working pretty well with people. Also, many of these patients might have some visual symptoms which are important. Glare, daytime glare, or dry eye, or nighttime clarity of vision, gritty sensation. All these things are very important for us to consider when we are going ahead and advising refractive surgery or explaining refractive surgery to the patient. Just the last slide, that refractive surgery, and I was trying to find some literature on the quality of life, very difficult to find it, on the quality of life, but I did find a couple of articles, and they said that people were thrilled and to be able to use sunglasses which didn't have any refractive numbers. Their emotional well-being had improved. They felt that they were able to do more things now than before the surgery. They were eager to try new things, and I think if this works in some percentage of these people, I think it would be worth it. With this open thought, I would like to thank the panel once again and for the invitation, and end my talk. Thank you so much.
Thank you, Dr. Amit. Thank you. In fact, I'll request Dr. Kaushik Murli to lead the panel discussion.
Grateful for this opportunity here. So the reason possibly they had the refractive surgery talk was to showcase that in community India, we need to see how we can prevent people from requiring refractive surgery where the cost could be a barrier. So our panel discussion is actually focused on myopia control. Personally, I'm very thrilled to be here because I get to ask questions to some of my teachers and eminent seniors who've been people I've lent on to understand a little bit better. So inviting on the panel is Professor Dr. Rohit Saxena, who's a professor at the RP Center, AIIMS, New Delhi, Dr. Suma Ganesh, who's the Director Pediatric Services at the Shroff Charity Eye Hospital, Dr. Sumita Agarkar, who's a consultant at the Department of Pediatric Ophthalmology and Strabismus at Shankar Nethralaya, and Dr. Pawan Kumar, who's the scientist and myopia research head and consultant optometrist at the L.V. Prasad Eye Institute at Hyderabad. So in the interest of time, I think we'll just dive headlong into the discussions, and I'm going to start off with Dr. Rohit. We just saw Dr. Praveen's data where he said that we're going to have about 50 million who are probably going to be myopic by 2050. But there is a kind of a concern or a cynicism in mind saying that all these years we've been practicing ophthalmology, why myopia now? Is it under spotlight does it really even matter? Or are we really creating a panic? Is that something that is important for us to prevent?
So panic is already there in East Asia, where 80 to 90% of school-going children are having myopia. So panic, and probably worse, is the condition they are in. Maybe we do not need to panic, but we need to have a concern. If we manage it today, we probably would be able to stop us from reaching that levels. And even as Dr. Praveen showed, even 1 or 2 percentage point increase means a few 100,000 children in a country like India. So it's very important for a preventable disorder. And just to highlight from the very beginning, the most important thing, myopia is a lifestyle disease and has to be managed as a preventive first and then as an interventional disorder.
Thank you so much, sir. So my next question is both to Dr. Suma and to Dr. Sumita. Now, agreeing that myopia is important to prevent, what does it actually require to set up in terms of a myopia practice? Do you need special devices?
We don't need anything special to set up a myopia clinic, basically, but means, of course, for research purposes, yes, because our future, we have to, I'm so happy that Dr. Pawan is doing so much to try to prevent myopia, and also he's trying to, I was so happy to hear that he's trying to reverse it. That will be the ultimate research, I think, which is going to be there. But if at least what we can do as clinicians here is that we can have a myopia clinic. The myopia clinic requires means a very good optometrist, do good refractions. So a refraction set, an autorefractometer. Then we need a lensometer, because now lensometers are coming up with the myopia calculator. So that will tell us, it can predict the progression. So parents are always concerned that at how much will, at what level will the myopia progress. So you can enter some demographic details of the family history also of the parents and of the child. And you can also predict how much of near activity the child is doing. And you can tell the parents some amount, you can at least counsel them that we have to control the myopia. Then we need an open field autorefractometer. We don't have it, but Dr. Pawan has it. And we are trying to see if we can make it as part of our equipment, because it is important, especially when we are now going to go towards myopia control glasses. And so we need that equipment too. Then we need a pentacam, because as he rightly said, that keratoconus could be associated. So we need to do both these tests also, so we need a pentacam. But I also feel, being a strabismologist myself, binocular vision with myopia is also very, very important. We need to check the divergences. We need to check if there's any lag of accommodation. So we need to teach the optometrist that they need to do cover test, they need to check the accommodation facility, they need to know to do a MEM or a dynamic retinoscopy, because they can help us. Suppose if the child is having esophoria, we can actually, can give bifocals and prevent progression. Or if there is a lag of accommodation also, if you find out, that just giving normal glasses, myopic glasses may not be enough. So you may need to add bifocals to that. Otherwise, there's no point, it will keep on still progressing. So these points are very important, and we need to have these things before, so that your myopia clinic is fully covered, especially clinically. And of course, the research part is also very, very important.
Ma'am, is there any special training that you now have included as a part of your fellowship curriculum?
I think a little bit of awareness regarding additional things, as she said. In a research setup, yes, open field is required. But that 35 lakh equipment, which is not even available now, I mean, I would suggest we should really focus on good visual acuity estimation, good cycloplegic refraction, and a comprehensive eye evaluation that takes care of most of the. Maybe only additional thing I would really agree with Pawan here is axial length measurement, because that's something which is available across almost everybody. Because cataract surgery is done by almost everybody. Yes. And I don't think it is a job of only a pediatric ophthalmologist or strabismologist or institution to take care of myopia. Everybody should be capable of taking care of myopia, or at least prescription of glasses, which is the first step. And then counsel the parents regarding outdoor. This takes 5 minutes. Yeah. But yes, if you have to train your optometrists and you want to do a little bit more than just a vanilla myopia control, then I think lack of accommodation, I would say, definitely important, and binocular vision status, definitely. Open field, yes, good, but equipment is not available.
Impossible to get, like you mentioned,
Impossible
unless
to
we
get.
build one in India.
And number two, if you look at all the peripheral defocus glasses data, they don't mention anything about peripheral refraction.
So that has always been a question, saying that after taking all this data, what are we using it for? Finally, we don't seem to apply it. But I think a key takeaway, and this is something that we've realized in various clinics, is to actually measure the length of your refraction lane. Otherwise, you yourself are creating myopia progression by overcorrecting children. So make sure that the lane is at least 10 feet and make those little corrections in terms of what you're refracting. So Pawan, the question to you is, not every child with myopia progresses. Not everybody wearing glasses here has progress. So you have come up with a kind of a nomogram to identify children at risk?
We developed a protocol called IMPACT, IMPACT, simple to easy to remember. We said just because somebody is myope doesn't mean it's an axial myope. So I stands for identify true axial myope, map all the risk factors. IMPC, understand that what is really triggering, is it a progressive or a stable myope? Then put them on some strategy. So if you remember, IMPACT, when to start, and we say when do you stop also is a big question. So we relate it to refractive surgeons operate only when somebody is 20 plus, not younger than that. So we're saying myopia is also about that scenario. So please ensure you go on till the late teenage, and then you stop.
Perfect. So that kind of sets off the perfect segue to Dr. Rohit. You came up with the IATM study where you collated data from across the country. So what is it as a tool that you have for all the ophthalmologists or the eye care practitioners here in terms of myopia management and atropine drops?
So we know now that in across the world, most studies have shown a good impact. The doubters are the Caucasian studies, where the impact has not been as much. And possible reason could be that the Caucasians are not so severe progressors. So a not so severe progressor group, you give a moderately effective drug and you're going to get equivocal results either way. But across Asia, all studies have shown very good impact. In the IATOM one, which was a multicentric clinical trial, and then the retrospective collection of data of over 800 eyes, we found almost 50+% reduction in the rate of progression of refractive error spherical equivalent and about 25% reduction in the axial length. The dichotomy, we had another study in which we actually evaluated, and we found that there is a bit of anterior segment relaxation that is happening, which is actually compensating for a bit of that myopia. So that is why I think both Suma and Sumita talked about axial length as the real important thing, because finally you want to restrict axial length elongation and not just talk about or discuss refractive error.
Ma'am, the question to you is, we are anyway giving glasses, and the defocus lenses have now become very available in the country. So is there a particular set of children in whom you use that, or is it your first choice today?
Like I have given around like in the last 1.5 years, my experience is only for 1.5 years. We have given 55 DIMS. So we have done a study, and so what we found was that what we did in one group of patients, we gave primary DIMS, and the others who were following up and were already on low dose atropine. And we found that the progression rate with DIMS with low dose atropine was much better. So there was hardly any progress, 0.1. But when you have only DIMS, it was around 0.8. So we are still, it's just a 1.5 year follow-up, so I'm not really, but what we are seeing is that it is working. And we need to give, means now I've changed, but mostly I'm now trying to do more and more of giving DIMS primarily, because I do not know how long can we give atropine. So that is like a question mark. So if we start the child at 4 years or 5 years atropine, can we take it up till 16 years? Can we give it that long? So the child is maximum study period is 9 and 10 standard. So in that period, if we can give low dose atropine, maybe, but maybe the initial we cover with the DIMS, this is what I have thought. I mean, it's just, I don't know if I'm right, but because I don't know how long can we give atropine.
Yeah, I think for the audience, DIMS is kind of a spectacle lens that incorporates defocus segments. It's similar to driving a car when it's drizzling. So through the water droplets, you see clear, and the periphery kind of looks blurry. So the analogy is kind of similar how the child sees. They actually adapt very, very quickly. The fear we have is with the DIMS lenses, since they're looking so straight, does it have a long-term binocular vision problem? We don't know. Possibly.
We have studied in our 55, there was no change in the binocular function. The only thing was they were having peripheral for defocus, they were having a little bit of adjustment problems. We have told them to do eyes tracking for around 1 week or 2 weeks, which they're okay with.
Dr. Sumita, medicines, glasses, they all are long-term. The expensive glasses are not very cheap. So is it all about it, or is there anything else we can do, or something we can suggest?
I think we don't talk enough about lifestyle changes. We look at solutions which are, as doctors, we are trained to offer quick solutions. And parents also sometimes, they want to hear, okay, take this drop or use these glasses. But I think we have to take out that 5 minutes of time to talk to them about the lifestyle changes of like spending enough time outdoors, spending less time on gadgets, maybe cut off, follow the WHO guidelines for technology, which is very, very explicit that you should not have any handheld gadget before 6 years of age in the kids. So I think I have told them the links, and parents sometimes they find it nice even you say this is WHO guidelines. I'm not talking out of my hat. Look at this. There are 2 interesting papers which have come recently, not only just myopia, but they have looked at the other developmental indicators with gadgets. And they have found that vocabulary of the children and attention and imagination for children is much less if the children have access to, very early access to technology. So I think we have to talk enough about these handheld gadgets, specifically iTabs and your phones, mostly phones. And it all starts with when mother is trying to feed the child, and we have some technology access at age 6 months. So I think that we need to talk a little bit more along with our outdoor exercises,
Also,
good
the
lighting.
schools are not helping with the amount of homework and work and the pressure of academics that are coming in. So, Dr. Pawan, considering all the constraints, is
That
there
I
anything?
think Dr. Vashisht and Dr. Rohit
Yeah.
can, because this
So
needs
we
to
have
affect
schools
the
in
education
Bangalore.
policy.
We have schools in Bangalore where the children go in the morning at 7 and they're out of the school in the evening at 7. So where do they even see daylight? So when I tell them 1.5 hours in daylight, the child starts laughing at me. So I have left stumped there. So is there anything new in terms of research that is available that, like ma'am said, a magic bullet that we can hope for in the future?
I agree with Dr. Sumita that we ignore that time outdoors as a factor. But I think we've also oversimplified. We say that, okay, time outdoors, come back and see me after 6 months. Where outdoors is outdoors. Outdoor of my outside patio, lights are not that great. Under a shade, the lights are not that great. So the illuminance level we talk about in lux are 100 times more when you're in open play area. But if you're still outdoors but in a balcony, I think you're still 1000 lux, not going to help you much. So I think you said 5 minutes, I would take 15 minutes. So explain them where outdoors, how much time, what time of the day. Then also indicate that CR's close monitoring, I think, is the way to go. There are light therapies that are coming out. Spectral composition of light seems to play a role. The devices that are available in the market already, red light therapy for myopia, blue light therapy for myopia, violet lights. I think game is shifting towards light therapy for myopia as well.
Sumita ma'am, I'll come back to you. Now we know that this is a problem. And like we started off in the beginning, Dr. Rohit mentioned that there already is a lot of panic that is already there. So how do you balance it where the parents understand that this is an important issue, that they have to be pretty hands-on? At the same time, you don't treat it, unfortunately at times when you call it a myopia clinic, it looks like a tuberculosis clinic. Are we stigmatizing it? So how do you actually balance that out?
A little bit of fear mongering is good. Let me tell you that. I want them to panic a bit. So I do talk to them about the long-term implications of myopia. And a lot of them are already been are looking at refractive solutions. No disrespect for Dr. Gupta here, but we are not looking at refractive correction as correction of myopia, because by that time train has already left the station. If you look at it that way, if you are looking at elongation of the eye. So I think it is important that they understand the implication of the refractive error not in terms of glasses, but also risks later. So again, chair time.
I think, again, Dr. Suma, you did touch upon it, saying that how long do you put them on drops? So again, this is something that requires a chronic intervention. Children will come into us when they're 3, 4, and you're worried about progression now going on till almost 2021. So no longer does it arrest at 15, 16. So again, how do you kind of make sure that the parents and the children are not getting frustrated with this long duration, where there is no improvement, it's only no deterioration, so to speak?
Yeah, a lot of counseling, basically, as Dr. Sumita said. You have to sit and counsel the parents, because what you have to tell them is that we have to explain to them what is myopia. I think that's very, very important, to just not give glasses. Explain with them with the diagram what is myopia, what can be the harmful if the axial line grows to a certain length. I mean, I give and demonstrate them what happens if the cloth is stretched too far and you can get a hole. So I explain to them that you can get detachment, or you'll get glaucoma in later stages of life. So makes them understand like why they need to take the treatment, and it can be for a long period of time. And so I don't think the parents are, yeah, exactly, but in every other field of pediatric ophthalmology, there is a long follow-up. So I don't think any parents to me tell me there is a long follow-up.
So Dr. Rohit, again, AIOS does have its own myopia guidelines that you were again instrumental in bringing out. So are there any key lessons or learnings that we can share as a part of Vision 2020, or take it forward from there on?
I think this is a wonderfully designed session, and key messages are going out for everybody working with children. Screening must. We need to know how much problem is out there. talk about prevention in an IEC format with the children in school. Myopia is anyway already stigmatized. We know that as children. I know the problems I had to face. So it's already stigmatized. So the awareness has to increase about preventive measures. And the guidelines were essentially so that everybody of us can work at a single page, work combinedly to get this message across, the importance of prevention, the importance of lifestyle change. It's just like diabetes. I mean, you can't treat diabetes if you don't reduce your carbohydrates. So you can't treat myopia if you don't stop using the digital devices, if you don't increase your outdoor activity and your lifestyle change. So these are important messages in those guidelines, which I think all of us have to take to the people, to the children, to the teachers and the parents. And I think that's the key message I think all of us who are dealing with this must take back home.
Thank you so much. I'm going to again ask the other panelists, probably starting with Pawan. With children again having, this is the last question. I think we got the room late. With children again having to balance needs, aspirations and other extracurricular activities, is there something that we can do with the schooling system since we are talking about the community ophthalmology setting?
I think I will keep it short. In other countries, there's something called recess time. School doors are locked, children are in outdoor environment. I think we need to work with government to ensure we get that 35-40 minutes of recess time is fantastic. We tell 1 hour outdoor after school hours seems like it's impossible. Yeah. Something to be done within the school hours.
Dr. Suma, Dr. Sumit. Yes.
We're talking all this. All this discussion to me looks like centered around urban areas and the people living in urban areas. And 70% of our population is out there in the rural areas. So what do we do there?
So
do we segment the care into what can be done at the primary level, and this much percentage of myopia can be tackled right there at the primary level? Let's concentrate on that. This much can be tackled at the secondary level, concentrate. This is where you have to really get into research, studies, all that, urban care, advanced care, all that in the urban areas. The second is, we are forgetting the fact that what is more worrying in myopia is not the simple myopia and how we correct it. What about the 10 or 15% of complications and pathologic myopia? In India, that translates into millions of cases of retinal problems, glaucoma, cataract, and that we have to contend with. So, if we want to developing a strategy for uncorrected refractive errors, it has to be composite, involving all these different factors and facets that we have to face in our country.
Thank you so much, sir, for kind of winding down the session and also kind of giving a direction to the team at Vision 2020 in terms of how they could take this forward in formulating certain suggestions, guidelines that could be implementable in the years to come to prevent myopia both in rural and urban India, or the India and the Bharat as we'd like to refer it to. So once again, thank you so much to the Scientific Committee of Vision 2020 for asking us to be a part of this.